Thank you for joining us. The webinar will begin shortly. Welcome to today's webinar. PYA understands the importance of clear, relevant, timely information to the industries we serve, so we offer a variety of webinars, white papers, articles, checklists, and other tools, all for free. Subscribe to our e-newsletters, follow us on social media, and subscribe to our PYA Webinar Recast podcast series for audio-only versions of all of our webinars at pyapc.com. If available, presentation materials used in today's webinar can be downloaded from the handouts panel. You will also receive an email after the webinar with links to any available slides. All of our webinars are available on demand at pyapc.com. Please stay on the line after the webinar to complete a brief survey and post any questions you may have. Thank you for joining us. Here are today's presenters.
Thank you for joining us for the third episode of our Revenue Recharge series. Today, we will be discussing the topic of managed care contracting. My colleague Jane Jerzak and myself will discuss how to identify gaps in expected and actual reimbursement, our experience building analytical models that leverage historical claims to submit competitive payer reimbursement proposals, and how to monitor contract performance and promptly address reimbursement issues. My name is Jason Hardin. I am a principal at PYA and the Director of Business Intelligence and Analytics. I'm based in our Knoxville, Tennessee location.
Hello, everyone. My name is Jane Jerzak. I am a healthcare principal working with health systems on numerous reimbursement issues, payer contracting issues, and happy to be here to share some insights that we've learned along the way with respect to payer contracting.
Jane, can you describe a starting point for health systems to evaluate the current agreements they have with commercial payers?
Yes, one of the things that we like to do is to level set payer reimbursement as it compares to each other. So this is a sample of what we've done for one health system where we look at all the top payers and we analyze at a specific service line level, like inpatient services, outpatient, professional, and then we roll it up to the health system as a whole to really develop a image, information on what % of charges this payer is actually contracted for with the health system and how that relates to a % of Medicare. So we're really creating a context for payer-to-payer comparison as well as payer to Medicare comparison. We also take a look at the order of magnitude. So for this health system, you can see that payer H has the most material level of charges for the organization. So as we focus on payer contracting, that's really an important data point to understand. Now, payer H certainly isn't the most generous of payers. It's right in the middle, but it gives us a context of payer, how well they're paying, and the order of magnitude. So that's usually the first step so that we can understand as we move into a new negotiation where each payer sits and what to expect from that next negotiation. We also like to compare what's expected in terms of reimbursement, which is the chart on the left, with what we're actually seeing come through paid claims, which is the chart on the right. And you'll see that there are often gaps between what we should be receiving in reimbursement and what we're actually receiving in reimbursement. And then we develop kind of a scorecard of which payer is closest to the payer reimbursement expected versus actual, and which payer has the largest gap between actual and expected reimbursement. And here, Jason, you'll see that we have some payers that are only paying us 89% of what we expect. So now we really need to understand the why. Why are we not yielding what we thought we actually contracted for with particular payers? And how do we resolve those issues either through the claims process or in future contracts?
And later in the presentation, we'll go into some dashboards that explore that further and how we leverage historical claims data to have more insight to identify some of those issues.
Exactly, exactly. So I just wanted to point out that certainly comparing reimbursement with the external market is also important. We now have price transparency at the provider level as well as at the payer level, but we really are asking everybody to proceed with caution. The data is only good with what's been provided and analyzed, and sometimes the comparisons are not necessarily valid. So we do look at this as well, but we do proceed with caution as we compare contracted rates to others in the market. Now what I'd like to do is share some of the lessons we've learned along the way in terms of what may be impacting that gap between expected reimbursement and actual in your health system. The first thing that we like to point out, especially the last several years, is those hospitals that are getting reimbursed based on the APC method, the Medicare APC method. Medicare has created a list of what's called status C codes, and those codes are for inpatient-only procedures. That's fine for Medicare, right? We can bill a DRG inpatient, but what about your commercial payers? A lot of commercial payers and physicians say, hey, this patient's healthy, and we certainly don't need to do this on an inpatient basis. We can do it on an outpatient basis. So they've created C codes. The problem we're seeing many payers come up with is that they are not establishing reimbursement rates for some of these C codes. And when we pull some claim data and really understand how those claims are getting adjudicated, we're discovering that a number of health systems are not getting paid on these outpatient claims because they're status C, and the insurer simply has not created a rate for these codes. So we've shared with you some of the top codes we've seen come through with status C codes that may or may not get paid by your insurer. So take a look at these claims for sure, especially if you're getting paid on the APC system, just to make sure there is a method and a rate for reimbursement for your services. There's a lot of other things that we're seeing impact perhaps expected versus actual reimbursement after the contract is signed. One of the areas is that insurers are sneaking in new payment policies. And one new payment policy we're seeing is that they decide that if a procedure can be done in an ASC, and it's done in a hospital outpatient setting, they're reimbursing on the ASC fee schedule at materially less amounts. So take a look, make sure that isn't happening with new payment policies with your contracts. The second is that some payers are insisting that outpatient lab services are done in a reference lab, not your lab. Well, you are really relying on that reimbursement. So take a look at that, and if that's impacting your reimbursement, you need to have a conversation with your payer if it's not part of your contract. The third item we're seeing is white or brown bagging on specialty medications. This was a big one in the past. Hopefully it's getting somewhat resolved. But again, you are expecting to receive drug reimbursement. Now that drug reimbursement is gone, those services are only getting paid for the administration of the drug. Again, a new payment policy that's impacting your reimbursement, and what are you going to do about it? And fourth is a very complex set of items, but proceed with caution when you're adding any new sites of care, whether it's in your facility, on campus, an off-campus facility, or a new micro-hospital. All of these new sites of service have very different implications for reimbursement. Before you proceed on these new sites, please make sure you understand carefully the reimbursement implications, making sure it's what you intend for your facility and your system. This is just a little example of pain management. We're seeing a lot of pain management done in outpatient settings at high reimbursement rates. Well, the codes that I'm sharing with you can be done not only in an outpatient hospital setting, but an ASC and also a physician clinic at very, very low rates compared to a hospital setting. So take a look, where are these services done in your facility, and make sure that you're not having a risk of those services getting moved to lower settings or lower reimbursement without you understanding the implication of this for your facility. Light item denials, we're seeing IV therapy, respiratory therapy getting basically line item denied on inpatient claims, particularly that are getting paid as a % of bill charges. If that's happening to you and if that's not covered in your payer contract, you need to do something about it, because the reimbursement implications could be very material. There's other reimbursement challenges with bundling that I've listed as well. Take a look at some of these for your organization and make sure that these are not unintended reductions in reimbursement based on your contract in place for your facility. We're also seeing high deductible plans, your commercial contracts. If you're not receiving reimbursement for those patient pay amounts, that could be materially impacting your commercial reimbursement overall. About a third now of employers are in some type of high deductible plan, and certainly that needs to be considered as you move into negotiation for your next payer contract. How much is that impacting your overall reimbursement from that particular payer? Last but not least is denials. Certainly denials with Medicare Advantage and commercial plans are absolutely on the uptick. I think we all know and appreciate that. I just wanted to share some of the top reasons for claim denials and make sure that we're doing our part as providers in sending through claims accurately. When I look at the top 10 reasons for claim denials, some of these are, in a sense, functions that we own as providers. So make sure that these top denial reasons are properly addressed by your facility. We'll be doing more discussion on denials in future webinars, so I'm not going to focus on these, but do take this list and make sure that you are doing all you can to address these items that you can control within your organization. So Jason, I'm going to turn it over to you now, because we've built some really interesting analytical tools that can identify some of these key issues, why organizations are not getting reimbursed what they thought they were getting as they entered into these payer contracts.
Thank you, Jane. Before we touch on the analytical models, I wanted to briefly touch on the payer and provider disputes. We'll be discussing this further in the July 11th Revenue Recharge series, but just to touch on this briefly as maybe a teaser to what's to come. If you've seen recent headlines, it's no surprise that there are a number of payer-provider disputes. These are just a few of the recent headlines on this topic. PYA has experience working with providers and dealing with payer disputes. Over a period of years, if you're not addressing issues related to disputed amounts, they can become quite sizable. In fact, a lot of the providers that we've worked with, it's ranged from millions to even hundreds of millions of dollars in some instances. As we've served as experts at PYA on these matters, we help to compute and validate what these disputed amounts are. Some of the topics we've seen have been downcoding of inpatient admissions, denials due to medical necessity, and then inpatient claims being paid as outpatient. However, there is a lot of work required to pursue these disputes. Many times it's through arbitration. So there are legal fees and an administrative burden to seek damages for these disputed amounts. So it does require a lot of effort. The experience that we have working with providers, more times than not, it is a favorable outcome. But we're going to explain some dashboards that we have developed to help identify some of these issues that could be systemic to address early on to perhaps prevent things from elevating to this level. Next, we're going to touch on how to be decision ready by leveraging analytics in managed care contracting. As the Director of Business Intelligence at PYA, we developed some unique solutions to prepare our clients to be decision ready when submitting payer reimbursement proposals and monitoring contract performance. Today, I'd like to share a few examples of how we've helped hospitals prepare to submit proposals to payers and monitor contract performance. The first example I would like to look at is related to a proposal that was being submitted for inpatient services. The contract was related to inpatient, professional, and outpatient. Due to the time, I'm just going to share what we designed for submitting a competitive inpatient proposal. The current agreement for inpatient services, this hospital was getting 78% of billed charges. This was not as competitive as some of the other payer agreements that were in place. To evaluate the rates that were going to be submitted in the proposal, we developed a dashboard that allowed them to work through multiple scenario iterations, looking at the base rate, obstetrics, newborn, and to come up with rates that were competitive and better aligned with their other payer agreements. Some things that we had to consider as we designed the dashboard were to look at the lesser of impact on billed charges or the allowed amount, identifying the number of outlier claims that hit the outlier threshold as we established that threshold, and then also identifying the reasonableness of types of services, or service types. For example, if we're looking at obstetrics, looking at the difference between vaginal births and cesarean births to make sure that difference makes sense. As a final step in determining the appropriateness of what we're submitting, we're looking at price transparency data. So for the top services specific to inpatient in this example, we're looking at market peers in the area to determine if what we're submitting in our proposal is competitive. What we don't want to happen is to have rates, if they were accepted, that are unreasonably higher, that may have the risk for the payer to perhaps redirect volume in the future to a provider in the market that has more appealing rates. So a lot to take into consideration. This dashboard was dynamic in the sense that it allowed us to work through these scenarios where we could fine-tune our proposal so it met the financial objectives of the health system.
So Jason, one of the things that we often look at, and I'm interested in if we analyze it here, is where hospitals are not charging rates to align with contracted rates, so that the reimbursement is limited by lesser of billed charges or rates. How does that factor into this analysis?
Yeah, you bring up a great question, Jane. What we're doing is we're looking at how many claims, what are the reimbursement implications of claims that do hit that lesser of threshold in terms of the number of claims and then that reimbursement impact. One thing to look out for, and we'll show this later in our contract monitoring tool, is if you're getting paid 100% of billed charges, likely you're being limited by this lesser of language. In other words, you need to increase your charges so that you're appropriately capturing the allowed amount that you're contractually able to receive. Next, I'd like to look at another example for a hospital that was evaluating building an ambulatory surgery center on campus. We wanted to model the financial implications of redirecting eligible outpatient volume to this ambulatory surgery center. So the process that we used was, starting from the beginning, we used the most recent year of all commercial outpatient claims. We then went through the process of identifying which of these outpatient surgical claims were eligible to be performed in an ambulatory surgery center setting. We did this by seeing, are they eligible to be reimbursed by Medicare, payer agreements that we have with commercial payers, and then determining not just at an overall procedure level, but for the entire claim, could all services on that claim be reimbursed in an ASC setting? For example, if we had, let's say, 3 procedures on one individual claim, and one of the procedures could only be reimbursed and performed in a hospital outpatient department setting, well, then we excluded that claim from the analysis. As a starting point to understand the reimbursement implications, we set an initial target rate of 295% of Medicare ASC as a starting point. We then looked at the delta between the existing reimbursement that we're currently receiving on that volume in a hospital outpatient department setting, and then comparing that delta to the 295% of Medicare that we set as our initial reimbursement goal. What we found, and this varies by service and payer, the range of the disparity between reimbursement in each setting spanned as much as from 20 to even 50%. So worst case scenario, you're losing half of the dollars when you shift specific procedures based on the existing payer agreements to an ASC setting. So the overall strategy that we had to look at is not just the reimbursement difference, but understanding what is the backfill strategy in the hospital outpatient department. So if you have more capacity in the outpatient setting, what additional volume are you going to shift for it financially to make sense? One other thing to consider is rates may vary based on the payer agreements that are in place. So whether you're looking at Medicare or specific commercial payers, you need to evaluate what type of mix makes the most sense to be performed in each setting. As we then drill down into the dashboard further, it's not shown on this page, we're looking at the mix of specific services. You can see the filter for service category. We're able to look at specific surgical services and to evaluate differences that exist in the reimbursement between the two settings. One last thing to note is that when we're looking at setting reimbursement at an overall service category, there are some exceptions that apply. So if we have specific key services, let's say for orthopedic or digestive surgical procedures, we may have specific carve-outs for those types of procedures to note. Jane, do you have any other observations to note or feedback on this particular dashboard?
Yes, well, this is eye-opening in terms of the order of magnitude of reimbursement difference, which really highlights a couple of things as I look at this. One is really to redesign your ASC contracts with payers, because certainly this type of reduction in reimbursement is unaffordable to really any hospital we may work with. So aggressive strategies and really understanding, as you said, the mix of services. And part of this project is really to determine what services might it make sense to move versus what services, quite frankly, should stay in the hospital environment. So I think the tool, the dashboard, is fantastic because it helps us to do a lot of what if scenarios to really help make some of these strategic decisions.
Thank you, Jane. The last dashboard we're going to share is a dashboard built for monitoring the contract yield. Jane's going to explain the background for this hospital.
Yes, Jason. This is a particular hospital that migrated electronic health systems and billing systems. So they did a system conversion of sorts. And it was very well planned, but after approximately 6 months on the new system, they were seeing a reduction in bill charges of almost 20% and a reduction in reimbursement of almost 20%. So the question was why? What happened in the system conversion that we planned that didn't go as planned? And why did we see this large reduction in charges? So we took a look, we got busy with claims information from the legacy system and the new system for approximately 6 months each. We went through carefully each service to identify what wasn't getting charged that was in the past. Our charges different now? Are supplies not billed and they were in the past? Is anesthesia time counted the same in the new system as the old system? We found just a whole host of issues that really resulted in this material drop in charge. So as we were doing this initial project, Jason, we also dropped in their expected and actual reimbursement by claim and by payer. And that's really what we're looking at here, that you've really shown this contract yield monitoring tool that helps us to understand the why. How are we receiving reimbursement compared to the contracted rates? And so I'll let you take it away in terms of what we've actually built for this particular hospital.
Thanks, Jane. So what we've done is taken the most recent year of closed outpatient claims specifically, and we loaded the contract terms to price expected reimbursement for the top payers for this particular hospital. On an ongoing basis, each month, we're able to then understand the delta between expected and actual reimbursement and the actual reimbursement or dollars being received. So out of this need for the hospital, we took their most recent year of outpatient claims and built a dashboard by modeling the contract terms to price expected reimbursement for the top payers to compare to actual reimbursement. So we could look at differences comparing each of the top payers, as you can see in the dashboard. We're then able to update this on a monthly basis so we can monitor what that actual to expected delta is on a go-forward basis. We then have the ability, if we see an issue at a payer level, we can drill in to a particular service category to see if there's some variable in the contract based on a particular type of service preventing us from actually being reimbursed what we're expected to be reimbursed per the contract. So this is one example of how to monitor the contract on a go-forward basis using historical claims.
And Jason, this is terrific because what we see, and not necessarily in this example, but similar, where lab schedules from payers wouldn't be loaded right, E&M schedules wouldn't be loaded, inflations for the next year wouldn't be loaded. One time we looked at this actual versus expected, let's say in June, and lo and behold, the client never loaded that year's updated fee schedule until mid-year, creating a material difference in reimbursement. And how is that going to get resolved? So this is really a great way, a great visual to help us to quickly take a laser focus on some of these areas that are reflecting the most material variances and really understanding the why. Why did this happen? What happened? Is it something on our end with billing, or is it something on the payer end with the load of the contract? So it's really a very, very helpful tool that saves time and also saves money, because now we can really focus on those issues and address them promptly.
Thanks, Jane. Well, that wraps up our revenue recharge series on managed care contracting. I hope today you learned how to monitor the gaps in expected versus actual reimbursement, how to make the most use out of the historical claims data that you have, and how to promptly address reimbursement issues that are identified for monitoring performance. Please join us in the next series on Medicare Advantage. Thank you.
Thank you so much to today's presenters. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. You will soon receive an email with the contact information of the presenters and a recording of the webinar. Also, the slides and recordings for every PYA webinar are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about our full range of services. On behalf of PYA, thank you for joining us and have a great rest of your day.